To our session called Opioids in Iowa for Iowa Ideas. Thank you for joining us. Um, I want to take a minute here to thank our sponsors before I get into introducing our panelists and our topic more in depth. Um, our overall sponsor, presenting sponsor for Iowa Ideas is ITC Midwest, based here in Cedar Rapids. They are the company you may know as maintaining the power grid in this area, working closely with Alliant and Mid-American and others to do that. And they're the overall sponsor of Iowa Ideas. Um, the Health and Human Services track sponsor, which is this session is part of, is sponsored by Tanger. I want to thank our sponsors not only for their commitment to helping shape a better Iowa, but because of their sponsorship, all this is free. This huge endeavor is free for anybody to join, and that's thanks to them. Let me introduce our panelists. We have a really good panel with us today. Todd Nowak is the executive director of Life Connections Peer Recovery Services based in DeWitt. Allison Lynch wears many hats at the University of Iowa, but I think the ones that apply here are she's program director of the UI Addiction Medication Fellowship Program and director of the UI Addiction and Recovery Collaborative. And Rod Courtney is the co-founder and director of the recovery community of Lynn County, better known as CRUSH. So thank you all for joining us. What I find particularly interesting about this is we have panelists with us who have lived experiences in the topic we're going to talk about. So we can go many different directions when talking about opioids, but we could certainly fill up the rest of the day talking about opioids. But in this case, I want to talk about that nationwide, we've seen a somewhat of a decline in opioid deaths, but it's uneven in different states. And Iowa already has one of the lowest rates of opioid deaths in the nation. But one of the big changes we're seeing is the role of fentanyl. Fentanyl keeps playing a much larger role in deaths and also just driving addictions, period. While all this has been going on, the legislature again punted on reauthorizing the opioid settlement. What this is that Iowa has been suing opioid makers and marketers because of the deceptive marketing campaigns. And the trust fund right now, the settlement fund, has over $25 million in it. And I was expecting another $144 million in the years to come in that settlement fund. And we wrote a story a few months ago about how this topic was likely to come back again in the legislative session starting this January. The people who control the legislature have different ideas on how the money should be spent, different oversights for that. And meanwhile, all these programs have been, all the funding for the programs have been put on hold, spending the money that's already been approved. So we're going to talk about that a little bit, but let me first start with something incredibly basic. I've learned after being in newsrooms for 40 some odd years that things we talk about in stories, sometimes we use terms that people don't really understand or don't fully understand. And Allison, this one is kind of directed at you. When we talk about opioids, what are opioids? How do they differ from other drugs? And what is it when we talk about opioids? What kind of drugs are examples of that?
Yeah, thanks, Craig. So in the end, opioids are kind of chemical, and I'll talk a little bit more about that. But they're chemicals that activate opioid receptors, and we all have opioid receptors in our body. Most of them are in our nervous system, but they're in other parts of our body as well. And they cause specific effects when they activate those receptors. And they're kind of predictable effects. One of them is that they reduce pain when an opioid receptor gets activated. Another is that it can bring about some people just feeling better mentally. And it also can slow down breathing, cause some relaxation, make people sleepy. Those are just the effects that happen when opioid receptors are activated in our bodies. So opioids are chemicals. There are a couple that are naturally occurring that come from the opium plant, the poppy flower. And so that's morphine and codeine are two opioids that are naturally occurring and can be extracted from the opium poppy. But then there's a lot of other opioids that can be made in a factory or in a lab. And so fentanyl is one of those that can be made in the lab. We call those synthetic opioids. And many opioids are used as prescription pain relievers, such as oxycodone. Fentanyl is a prescription opioid. Morphine is also a prescription opioid. Codeine, hydromorphone. There's a long list of them that are still used medicinally. And then there are some that are not used as prescription opioids, like heroin, which is another opioid.
We've seen this is true in Iowa and nationwide also, we've seen a really uptick in methamphetamine. That is not an opioid, right?
Correct. That methamphetamine is a stimulant. And so it acts on different receptors than the opioid receptors, and it causes different kinds of effects in the human body.
Of course, what we're seeing also in the rise of fentanyl is people cutting meth with fentanyl. And so it now becomes somewhat more complicated, right?
Yeah, we've seen a lot of contamination of the drug supply with fentanyl, and including now fentanyl being in the stimulant drug supply. And then so we're seeing more stimulant related overdose deaths, as far as like looking over time, overdose deaths, which substances or which drugs are involved in overdoses, and we are seeing more with stimulants in them.
I know that everybody here has programs going on that are dealing not only with this problem, but other addictions and other mental health things as well. I just wonder if we could go round robin and just talk about what's going on in your neck of the woods, because I think all of you have interesting stories to tell and share with our audience. Let me start with Todd. Interesting things are going on in DeWitt, and tell us all about that. How did that start, and what are you doing?
So, yeah, you're probably talking about Rondas House, which is Iowa's first and only peer-run respite. And the reason ultimately that I started this is because a couple of reasons. I knew about peer-run respite and what it was like. And I heard back when Governor Branstad was leaving, he was going to shut down the institutions and put a lot of money into the communities for integration. And ultimately, I've seen a little bit of that money, but I haven't seen all of it. And the other process that I thought about with opening this respite is that ultimately when a person calls us, we don't ask, okay, so are you dealing with addictions? Okay, great. Or, okay, sorry, I can't help you. We ask, what is going on in your life right now? What is the underlying issue that you gave us a call for? And ultimately, if we serve the person, that is really what we need to do, right? And I think we're moving there as a state, but ultimately at the respite house, we've served over 605 people in 6 years. And this is people all around the state. And we've actually had like 9 to 10 of these people move from where they were in maybe Cedar Rapids area, maybe Des Moines area, and now are living here and are working. And some of them are working for us at the respite house. And they can stay up to 7 days. They have to have a place to go and return to. But ultimately, they have the freedom to come and go as they want. And we offer the ear of listening. That's ultimately what we are taught. Yeah, we do share our story with them, but that's not for us to do. It's about them. And then also we share resources, different skills, things like that.
So the people who come to you, they're not necessarily addicted to opioids, and so it's a more of the broader services that bring people to you.
Yeah, I would say at least the high 87 range are people with co-occurring issues
Mhm.
going on.
Mhm.
But ultimately, it's what's going on right now because, I loved it one time I heard a state official say, well, that's not in the crisis service. And I'm sorry. Um, who's going to define somebody's crisis? Because if I lose my car keys, I may have a full-blown car crisis. And if I end up dealing with addictions, I may have a full-blown crisis. So ultimately, that's what I'm saying is we're serving the individual for what they consider their crisis at that time. And, in that situation, we've served a lot of people that tried to get the treatment that they needed, but were put on a waiting list, that were sent home, and then ended up using again.
Mhm.
Todd, how is Rondas House funded? Is it insurance? Is it donations? Or is it how does that happen? If
Yeah.
somebody wants to avail themselves of this, how do
Yeah.
you?
Yeah, so with being a peer run organization, is one of the things that we don't do is we don't bill Medicaid or insurance. And the reason for that is there comes rules, right? And with rules, there's caps, the cap of how long you can work with somebody. And, ultimately, I feel and my organization feels that people are not medicine bottles. We shouldn't put caps on them. And that's why peer run organizations don't do it. So ultimately, the way that we are funded is the majority of the funding that we receive is from the state of Iowa, which is really awesome. That's how most respites are funded. And then the other part of our money is through our 5-county mental health region. So that's going to look a little bit different now that we're going to be going to districts.
Mhm.
And do I have the answer for that right now? No, I don't think a lot of people have the answer, but ultimately, I think this is why we are shifting this, right? The governor says prevention. The governor says recovery. The governor says support. That's everything that we're doing here.
Mhm.
But let me ask you, and your experiences in Lynn County or the services you offer are different, but they're sort of similar. And I
Mhm.
just wonder if you can talk about what Crush is doing and also how that came about.
Okay, thanks, Craig. Uh, well, I always have to go back to November 1st of 2016 when my wife and I lost our son to an accidental fentanyl overdose. He was obviously a heroin user. On that particular day, he wound up using fentanyl, and he passed away as a result of that. So I was at the time I was working as a probation parole officer. There were some folks from the law enforcement came into a presentation. They were with HIDA and Eastern Iowa Heroin Initiative at the time. And they did this presentation and they talked about a lot of things like Dr. Lynch just talked about. This is an opioid. This is the heroin. These are the different substances and where they're coming from. And after that, the the officer that was doing this at the time said we wanted to start family or support groups across the state for people that have been impacted by, at that time, it was heroin. Crush originally started as Community Resources United to Stop Heroin. We've since changed that to Community Resources United to Spread Hope for reasons that will become more obvious as we talk more about how Crush has grown and changed. But I went up to that officer afterwards, and of course, I ran a lot of groups over the years, and I just said I'm all in. So Debbie and we got started with our Crush Family Friend Support Group. It was started off very small. It started out here locally. My time in probation parole, I always enjoyed spending most of my time out in the community. So I had places that we could hold the meetings pretty readily, and it just started from there. It started with just a couple people, and then there was, it grew to the 20. And Deb and I would go across the state and do what we call a chat story. which is really the progression of his addiction from his teenage years until until his death. And until we did that for, I guess we've actually been crushed for about, well, it'll be 7 years coming up here. It'll be 7 years, but and then we had opportunity. There was a SAMHSA grant through the state of Iowa to open a recovery community center. And I had been trained as a peer recovery coach back in 2018. At that time, it got put on my heart, my mind that this is what I wanted to do, is start filling these voids. And Todd has talked about some of those. People are sometimes waiting. There's just not enough beds, and so they're waiting. So where's that oasis? Where's that place they can land? So we started Crush, and it's we're a multiple pathways. So we don't adhere to any one approach, although every approach is welcome. And if you look at our calendar, you'll see. I mean, we have everything from Bible study to pagan to to art to it's what in the recovery community. This is a peer-ran, peer-led center. Everybody here has had lived experience around some type of substance use disorder, and to the point that was made earlier, oftentimes there's a comorbidity between brain health and substance use disorders, and they go hand in hand. More times than not, I think. So the folks that are here, they're trained as peer recovery coaches, and they go through the training right up to including ethics, and we just went to work. And it's a lot of this has been very, very organic in the sense that because it does come from the recovery community or what they feel that is something that's needed. The groups are built around that. We have, and some people probably get tired of hearing me say this, but I heard something somewhere. It's like we meet people where they're at, but we don't leave them there. So we follow up. And it's like right now we're serving anywhere from 14 to 1,800 people a month, and some of that's done through outreach, some of that's done through groups, and a lot of it's just walking. We're walking. So if you're having a tough day, if you need resource, they come in. So I think that kind of gives you an idea. I got to be careful because we have so much fun. Our calendar is so full that I could probably eat up the whole 40 minutes just talking about the remainder of the time, I should say, just talking about Crush. But that kind of gives you a sense of how we started, what we're about today. We have amazing community partners. Lynn County has been so welcoming and understanding that we're just here to pull up alongside of people. We just want to pull up alongside of people and help navigate through the system at some really tough times.
Thank you. I do want to talk more coming back to the role that peer coaches and recovery specialists play in this. Mm-hmm. But first, let me ask Allison, you have some interesting things going on in the University of Iowa, including the vans that you have. And I just wondered if you could talk about that program, talk about, going where people are, meet people where they are. I think that certainly comes into that equation as well.
Yeah. So at the University of Iowa Addiction and Recovery Collaborative, we have kind of 4 main areas that we work on. And one is education. So we have a lot of education programs to train various health professionals on working with people who have substance use disorders or who use substances. And then we're involved in some research. We do outreach and advocacy, but a lot of what we do is our clinical services, and we have services here at the hospital. We have a clinic for people that are seeking medical treatment for a substance use disorder, and we have some other more behavioral and group focused treatment programs. But one of the things that we've been able to do more recently is to purchase a van and create a mobile clinic. We were very lucky to get some money from the Iowa Attorney General's office as part of the early opioid settlement funds that came to the state, and we used some of that money to purchase our van. And so it's a van that was kind of converted into a clinical space. So literally we have a desk and a chair and file cabinet and then seating. And we take our van right now we take it once a week to Cedar Rapids, to 2 different locations. And so every Tuesday, I'm either at Heart of Iowa, which is a substance use treatment program for pregnant and parenting mothers that's part of ASAC in Cedar Rapids, And I'm there one Tuesday, and then the next Tuesday I'm at the Larry Nelson Center and Gerald Hinsman Center, which is part of the District 6 Community Corrections Campus. And these are two locations where we know that there's a larger number of people that could benefit from addiction treatment, but they don't have access to medications that we can prescribe in our van as easily. And so we bring our care to them. And I like to try to combine lots of different things that we're working on. So I always bring my my fellows. So these are either a nurse practitioner, a physician assistant, or a physician that's spending a year with us, getting more specialization and expertise on working with substance use disorders and addiction. So I bring a trainee with me. I also bring a recovery coach or a case manager. And we also have hired, I think we have 4 recovery coaches right now. These are peer support specialists that work with us. And so we are able to bring kind of a comprehensive team of people to be on site with and evaluate patients. And it's like in a lot of ways, it's a lot like what we do in our clinic here in the hospital. We have a laptop, we evaluate people, come up with a diagnosis, we make treatment recommendations, we talk with them about what their goals are. We can send prescriptions directly to the pharmacy where they can go pick up their prescriptions and start taking medications. The van is specifically focused on medications or the medical treatment of addiction. So it's one part of addiction treatment, but that's what we are using the van for right now. And our plan is to expand and bring our mobile clinic to more locations. And so that's why our education program is so important, because we need more people to do this work. And so we're training people so that we can expand the reach of the van.
I believe you said that about half that grant is gone. And so obviously that limits what you can do in the future. Do you have any plans for any ideas when you do ultimately expand it, where it would go, or what are your plans for expansion? Or are they set yet? Or, if I had money, this is what we do. We'd add these other locations to it or hire people. I don't know if it's gotten that far yet or not.
Yeah, I've had some conversations with some different people, and we are always applying for grants so that we can get more funding to continue to expand our reach and our interventions. I would like to bring our van to Hope House, which is another halfway house in Johnson County. I would like to bring our van to a site in the Quad Cities, because we see a lot of patients that come to us either in person or through telehealth to our clinic. And so I think that there's a need there, particularly with the halfway house there. I'd like to work with them. And I also have had some conversations with some people in the Burlington area and Keosauqua area, and we'd like to bring our van down there. So those are all works in progress. But just we really want to make sure that people all over Eastern Iowa in particular have access to medications for opioid use disorder. And I will add that UCS in Des Moines, they have a mobile clinic as well. And I know they're working on trying to increase access to medication treatment for addiction with their van in more central Iowa and also some western Iowa.
If you could talk to us a little bit more about medical addiction therapy. How does that work, and who is it appropriate for? And those of us who couldn't survive a week in medical school, keep us in mind when you describe this. But I don't know what's involved in that or who qualifies for that.
Yeah. Okay. Definitely ask me more questions or have me explain something if I get too complex about it. So for the medical process, we start by taking a history from somebody and asking them about the symptoms that they've had related to substance use. And the diagnoses for an addiction are really about the behaviors that happen after they have been using a substance for a while. So it's actually, if someone says, I use heroin, that's actually not part of the diagnosis. It's more when somebody is using heroin and they have, they try to cut back and they can't, or they need more heroin to get the same effect, or the heroin, like they spend time worrying about where, if I don't get some more heroin, I'm going to start having withdrawal symptoms. And so then they start spending time thinking, okay, where can I get some? Or, how am I going to manage other things? And it can sort of take over more time in their life and more to take up more of their thoughts and their just, I think of it as brain space. So they become more preoccupied with making sure that they don't go into withdrawal. So we ask questions about that. We do want to know, when did people start using a substance, and how are they using it, and why are they using it? How does it make them feel? But we also ask about things like, do you need more to get the same effect? Do you get withdrawal symptoms if you don't use the substance? Is it interfering with your relationships with other people? And is it interfering with you being able to do other things you would otherwise be doing, like organizing your house or getting to work, or those sorts of things. And so then once we have gone through and taken a history and kind of gotten a good sense of all the symptoms that are related to their substance use, we can make a diagnosis of a substance use disorder. And then we talk with people about what their goals are. And some of the people we see want to stop using all of the substances that they've been using. And other people may want to just focus on one substance at a time. And other people want to maybe use less, maybe not have it cause as many problems in their life, but they're not ready to completely give up the substance. And other people just want to make sure that they don't develop other problems from substance use, like they want to reduce the risk of getting infections or of having a hangover or of overdosing. And so in our clinic, we really, like Rod and Todd were both saying, we also try to meet people where they're at and find out what are they ready to do, what is their goal, and then we talk with them about different ways that they can do that. And it might be prescribing medications, and I can talk more about the medications that we use, but it might be going to like a support group, or going into therapy, or going into like a 30-day kind of rehab program, or might be just like finding some mentors and a support system, or lots of different ways. And often people want to do more than one thing, and people find benefit from doing more than one thing to address, like maybe they might take medication and go to a support group, for example.
When you talk medication, you're not prescribing methadone, right? I think that's what people comes to their mind first when there's a heroin addiction or something else.
Yeah. So depending on what substance use disorder somebody has, that'll help us figure out what would be the right medication. For opioid use disorder, there are 3 medications that are FDA approved to treat opioid use disorder or opioid addiction. And those are methadone, buprenorphine, and that comes in several brand names that people may be more familiar with, either Suboxone or Subzolve or Subutex. Those are the brand names of buprenorphine. And then the third one is naltrexone. And methadone and buprenorphine are both opioids, so they actually have a lot of rules around prescribing them. And naltrexone is an opioid blocker, but it's not an opioid. And so that one has less rules around it, as far as, it's not a controlled substance. And buprenorphine and methadone are actually the most effective treatments for opioid use disorder. And what I mean by that is they both dramatically reduce overdose deaths, and they reduce morbidity and mortality related to opioid use disorder. Methadone can only be currently in the U.S. Methadone is only prescribed or used to treat opioid use disorder in what we call an opioid treatment program, which is the official name of a methadone clinic. And buprenorphine can be prescribed out of any office, any medical office where the prescriber can write for other controlled substances. Like if they can write opioid prescriptions, or they can treat with other, if they have a DEA license, they can prescribe buprenorphine and treat opioid use disorder in their regular clinic. So our mobile clinic is like a regular clinic. We don't prescribe methadone out of the mobile clinic right now. We just prescribe buprenorphine and any other medication that we prescribe in our clinic. And we are in the process of becoming a methadone clinic or an opioid treatment program. So our goal is to actually be able to also offer our patients methadone, but currently we are not certified as that.
And so would that be on the mobile clinics, or would you have to come to the University of Iowa to have that?
Well, in the past, say 6+ years ago, we would have needed to just do it at our hospital. But one of the COVID really changed the landscape for substance use treatment. And one of the things that happened as a result of COVID was making it more accessible to access buprenorphine and also methadone. And so now methadone mobile units are an option. And so actually our goal is to have a methadone mobile unit, which we think makes a lot of sense in a rural state where people are spread out, and there's a lot of barriers for people to get to Iowa City or to get to the nearest clinic. And so we want to be able to bring treatment to people. We think there's a lot of benefits to that. So our goal is eventually to get a mobile methadone unit.
I want to get to Todd and Rod about another question, but one quick question on that. Is there any time frame when that might happen?
We have applied for a grant to buy a mobile methadone van, and we're waiting to hear back on that. So it really depends on funding. It's probably the next thing. We're also working with the University Hospital to find a place for our methadone clinic to be located. And those conversations are ongoing. So hopefully in the next year or two, that would be great.
Thank you. Todd and Rod, I want to ask you, looping back to the peer coaches and peer recovery specialists a little bit. I'm sure you know how powerful that can be for people when they're talking with peers about issues they're facing in their lives. I've always talked in the newsroom about how every time I write a story about cancer, it resonates with a lot of readers because either you have cancer yourself or you have somebody close to you who has cancer. Mm-hmm. I think that's pretty much true when it comes to substance use also. Mm-hmm. People either have an issue themselves, or they know somebody close to them who does. And I know that both of you have lived experiences. I just want to talk a little bit about some background about how you. Rod shared with us before when he co-founded Crush. Todd, I wonder if you could talk to us a little bit about when you decided that, hey, I need to do something different with my life, and what grew out of that in terms of Rondas House and all the other projects you're working on. And I want to loop that back into kind of the power of peer recovery coaches and specialists in your ongoing operations.
Yeah, so you're asking basically about my own recovery journey.
Yes. Uh-huh.
Yeah. So yeah, it's I never thought I'd be where I am today. I spent 18 years in sales and management and rent to own. And as you can imagine, that's what got me down this journey, is I ended up hurting my back. And so the answer back then was, well, let's give this person Oxycontin, let's give this person oxycodone, let's give them Vicodin, morphine. And I was on 5 painkillers. And it got to a point, after surgery that that wasn't enough. And cocaine became an answer for me. And when I found that, wow, I've got a huge problem here, it was a struggle. And back then, like Allison said, I ended up going to a methadone clinic, and that was one of the hardest points in my life, because when you're going through that and not feeling like you have support, it is tough. Because I went through night sweats, I went through day sweats, I went through times where I felt like I was coming out of my skin. I was very agitated, didn't help my relationship. But thank God for my relationship, because if I didn't have a good relationship with my wife or even my family, I don't know, I probably would have went back. And it was tough, right? Because I then began to notice that it wasn't just, okay, fine, I was on all these narcotics and I was on cocaine, but then I realized that this physical pain right? So how am I going to overdo this physical pain? And so for me, it was really, I was a person of broken in addictions. I was broken in my emotional mental health. I was broken in my physical health, and I was broken in my spiritual health. And so I believe for myself that 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 was tough. And I had to find the right people to support me for the right things, right? And I truly do have people to support me on all them things now. Um, but that is a very big challenge for an individual, you know. And I just want to talk about too in my own recovery journey that, you know, the impact that this made on my family. Because I am going to tell you that through that, I did try to take my own life. I did. I don't hide that. I don't talk about certain things, but the impact that had on my younger children and having to go to my children's school and trying to talk to them, and they were mad. They were mad. They didn't understand, and it was a journey. But you know, the thing that I find now in my recovery journey, and I am still on, and nobody ever recovers. I truly don't believe that. I believe we walk every day by the grace of the good universe in a recovery journey. And I think with that, I grow, right? And that's where I'm able to take my lived experience, right? As I said, I was in management and sales. I've never been to college, but behind me on my wall sits in a frame a certificate of a PhD. And that is a personal history degree of a lived experience of chronic pain, emotional distress, addiction recovery, and spiritual journey of being broke. And you know, I got to tell you, Allison probably paid, and a lot of professionals have probably paid a lot of dollars for what they have. I've paid a lot in my life for what I have.
Thank you for sharing that. And that's a powerful story. Unfortunately, there's a lot of us who we have friends and people close to us that we find out too late uh, to do anything about their suicides, their addictions. And so that's a very powerful story, and I'm glad you shared it with the group here. Um, what's so interesting about that is that both of you have gone on to affect other people's lives for the better. And I just wonder if either one of you could talk a little bit more about how you took really rising, from the bottom, the depths to creating these opportunities for others that and how you grew it and got people involved in it. Ron, I don't know if you can talk about that. I mean, you started to talk about this a little bit earlier about the you were on board with doing this and how it's grown, but I just want to talk a little bit about recovery coaches and specialists and the power that they have, which I'm sure you're included, in this as well, but other people on your staff, um, uh, what power they have with people who avail themselves of your programs.
Okay. Well, again, going back like 2018, when I trained as peer recovery coach. At the time, I was training to be a trainer of trainers, and it really started out. The power for me started out when I felt the energy in that room of people that they're looking at multiple pathways of recovery and how they can utilize that not in their own lives, but how to share that with other people. So that is what started it. My process of recovery, my own recovery, has been less than, I guess, what you call the traditional kind of approaches. It's when I was working probation pro, and I was also or not probation pro, but I was worked as addictions counselor. I caught myself towards the end of that is like hammering out almost cookie cutter type of plans. You know, you go to AA meeting, get a sponsor, read this, do that. And so it's and because my process was again less than traditional. I mean, I kind of fell into that process. I started looking for other ways. And if you haven't ever read the Bill White papers, do, because he's almost the father of, of peer recovery coaching and multiple pathways, at least in my opinion. So when I had that opportunity, I hope I'm stringing this together here correctly, but when I had that opportunity to share that and bring peer recovery coaching to Cedar Rapids, it literally, and I've said this quite a bit, we've been building this airplane as we're flying it. It's like we got some peer recovery coaches and we felt the impact. And the things that I've noticed from that, people come in and say, it feels comfortable here. I feel comfortable here. And we talk about things, we all have lived experience. So who are we to judge? I don't feel judged when I come here. And I think there's a certain level of comfort when you talk with somebody that has that shared experience. Like Debbie and I, when we started our family and friends support group, we were looking for people that had the shared experience of losing a child to a substance use disorder, and also discovered the power of community in that. We talk a lot around here about, and this isn't new. I mean, this is said in a lot of different places, but the opposite of addiction is connection. So people can come here and they can connect. And however that happens, we have a bunch of volunteers, a lot of who have been trained as peer recovery coaches. So when you come in and you sit in our front area and you start having a conversation, now there's somebody that's had this, all these different life experiences and are able to share at that different level. They talk about the stages that change. They can use motivational interviewing to help move that forward. Because we meet people where they're at. If they're still using, but if they're interested, we're here for you. I hope I'm answering your question, Craig.
No,
But it's
I just,
it's that kind of journey. I'm sorry. Go ahead.
yeah, I was just picking up a little bit of, again, on the topic of meeting people where they are. And Todd, I think you said this, meeting people where they are and not leaving them there. Both of you probably have people who've gone through your program still in contact with you. I think, was it Todd said that people call you like every day? I just kind of wonder what the follow. Let's say you go through the program. What is the follow up for somebody?
Yeah. So I just want to say that, we have Rondas House, the only peer run respite. It's only one in the US in a rural area as well. And we did that specifically because that we're better to have your recovery journey, right? Instead of a big city. But we also run the only after hour wellness recovery center. And that is open from 4 to 10 at night in Clinton. And that's during the week, and then noon to 6 on the weekends. And I would say the majority of the people at the respite house, they stay connected because they feel like what Rod said, right? It's inclusion, right? So many people are excluded, like you said earlier, and I kind of hem-hawed when you said it. I was like, oh my gosh, he's saying what I hear in the pews of my church every Sunday. Let's pray for Jim. Jim's got, pancreatic cancer. But when I say, hey, can we pray for Bill in fighting this battle of meth? It's like, oh boy, I don't know if I want to open that door, right? But truly, that's what people feel. They feel connected, right? I'd be honest with you, and I can guarantee you that if you interviewed every one of the guests that have come to Rondas House, not one of them has ever wanted to leave after 7 days. Never, right? And I call it the bed and breakfast for your emotional distress and life interrupting challenge for a reason, right? Because that's truly what it is. We all have that, right? Why do we go to a bed and breakfast? Why do we go to a hotel? Not to spend a lot of money, right? I think we can all use a lot of money to buy groceries nowadays. We go there to ease our stress level, right? To reduce our, inner parts. And that's truly why the people are coming there and the recovery center. We have 2 people that use our wellness recovery center that live in Iowa City. And the reason that they come is because we've been able to educate them too on how to use the and not use the system, but to actually use the system, right? So they have Medicaid. And so with Medicaid, there is the MCO process that they provide transportation. So we have educated these two folks to use that to get them there. And it's really cool because rideshare will bring them and it's up to them on how long they stay. Like Rod said, right? We meet them where they are. How can I support you in your recovery today? And they stay as long as they want. If it's to be in the group that's being held that day, if it's to be just in connection, like Rod said, to feel included empowers somebody, right? And if you give me the time to listen to me, I'm going to love you a lot more than I love this person staring at a computer desk and writing down stuff. And that's truly what I think Rod and I built together is, and also, like Rod said, is, this whole thing of, do you have a mental health? I just get so tired of the silos, right? I mean, I know we're Iowa and we have a lot of silos out there, but we need to start breaking them silos down because for too long they've been siloed. I think I talked too much.
No, thank you very much. I wanted to switch gears a little bit here and ask Allison this question. We've been talking, there's been dialogue for a long time about ways that medical professionals can look at reducing prescribing opioids to patients, whether they're in for surgery, what are the other options. And I know that the billion pill pledge is along those lines. I just wonder if you could tell us a little bit about the steps that the medical profession is taking to reduce our reliance on opioids.
Yeah. And I think it's even broader than that. I think we also just need to be more aware of substance use disorders and addiction as having a medical component to it and trying to both prevent people from developing an addiction to opioids, but also to make anybody who comes to a healthcare office should feel welcome, they should feel respected, and they should feel like they can ask to get their needs met and be treated in a way that makes them feel listened to and safe. So I think there's things on both ends. And I actually think peer recovery coaches are a part of how we help create a safe and respectful and trusting environment for people that are coming into the healthcare system that may be struggling with a substance use issue or an opioid addiction. But as far as trying to prevent more people from developing opioid use disorder or addiction, I think there's a lot of things that need to be addressed, but one of the things that with the billion pill pledge, which is another project that the state used some of the opioid settlement funds to invest in, has been to provide both education and support to healthcare providers and patients who are undergoing medical treatments. So in the past, there was a belief that opioids weren't addictive. The prescription ones weren't. If you got a prescription, you wouldn't have to worry about getting an addiction. And there was also a lot of emphasis on make sure people have no pain. And so it was very easy for healthcare providers to write prescriptions for a lot of opioids if somebody came in and had pain, or if somebody had an injury, or if somebody was having a procedure. So it just wasn't, 10 years ago, if you came in for a knee replacement, you might leave the hospital with a lot of opioid pills. And now we know how that prescription opioids are, people can develop an addiction to that. And they're not risk-free. And so one of the things that has happened is that there's a lot less opioid prescribing in those sorts of settings. So if somebody comes into an emergency room or an acute care setting, urgent care or something, they're not likely to leave with a prescription for a lot of opioids. They may get a small amount, but they're not going to get as large of an amount as they might have gotten 10 years ago. And if somebody is having surgery, they're less likely to get a large prescription of opioids. And the billion pill pledge is really around providing information to surgeons and nurses and other healthcare providers on things that we can do for a patient before they even go to surgery to reduce the chances that they're going to have as much pain. So things like being well hydrated, sometimes doing physical therapy even before you have surgery, focusing on nutrition, focusing on pre-medication with things like Tylenol and ibuprofen can actually reduce the pain that somebody has after a procedure. And so there's a lot of good evidence, things that we can do that reduce pain from surgery. So the Billion Pill Pledge is really about trying to help healthcare providers and patients do the things before they have surgery to reduce their need for post-operative pain medicines. And then also not having opioids be the first and last thing that we offer people who have pain, but thinking more broadly, there are other non-opioid pain medications, things like physical therapy and other interventions can also address pain or reduce pain. And also looking at other underlying issues or comorbidities that could be contributing to somebody's ongoing pain issue. So I think that's a really important transformation that we are seeing. I think there's a lot more room to continue to publicize that we can take a proactive way or approach to work with people in the hospital setting or in the medical setting and reduce their need for opioids and reduce our reliance on opioids as being the answer for pain. But I do think that at least identifying this, and I think we've made some early steps in the right direction to try to have the healthcare setting be less focused on opioids and less in the habit of exposing people to opioids when they probably could have had some other options.
And you mentioned something earlier that I never would have put under this category, but it makes sense. There's been a really explosion of less invasive surgeries that are happening right now. And so the recovery time of those is much less when people might be subjected to pain. I just went through one of these 2 years ago myself to get a mitral valve repaired at the University of Iowa, by the way. And I mean, I was in the hospital for like 3 days. It was almost an outpatient procedure. And the pain was very minimal afterwards. It was nothing really. I never would have put that in the category of steps that our doctors are taking to reduce the amount of opioids they're prescribing. But that certainly qualifies.
Yeah, absolutely. And there are less invasive options for a lot of surgical procedures. Around the time that I started my medical training, they were still doing what we call an open cholecystectomy, or actually opening up the abdomen to take somebody's gallbladder out. And now, unless there's a really good reason to do it that way, anyone who comes in to have their gallbladder taken out is going to have that done laparoscopically, where they put a couple small holes in the abdomen and then do it kind of on video almost. They have some tools that they can stick through some small holes and they can remove the gallbladder in a much less invasive way. Yeah, that, and I think, there are other, there's been trends to maybe less surgical intervention for back pain and more non-surgical intervention for back pain. I think there used to be a mindset that, oh, surgery, that's like, you just go in and they fix it and then they get out and that will solve the problem. And I think there's better understanding now that not all problems are best suited to surgery and that non-surgical options need to be considered. So yeah, there's a lot of different ways. I think also getting people up and moving after surgery is much more common now than it used to be. And getting people out of the hospital sooner, not before they are medically stable, but it used to be if you had like a knee replacement or a hip replacement, you'd be in the hospital for a week or more, and you might be in bed for a few days before you even got out of bed. And now, pretty early after surgery, after those procedures, people are getting up out of bed with a physical therapist or with the nurse to start moving and use ambulation. And it turns out that people recover better if they move around and get the blood flowing and use their joints. So all of those things that can contribute to trying to reduce the need for pain medicines.
Todd, you had something to add?
I do actually, as being a person that has gone through multiple of that, 3 back surgeries, 2 knees, going through my neck. I can attest to that. It used to be, like I said, I would go and get cocaine for that pain. Now maybe go for a walk in the pool. That really reduces the stress level on the joints. Dry needling. I just had in May, a 5-year knee replacement got infected. And I was in the hospital for 10 days. And it wasn't because of my knee, them having to go back in there. It was because of the infection. But even though that infection, I did not want to be in that hospital. And I knew what I had to do. And that was great, being able to know what it is you had to do. So I'm just saying there's dry needling, there's massage, there's I don't know if you've ever heard of a float tank, but the float tank is really good for pain. So I just wanted to throw that out there that, I have other fixes now, and it could be walk and listen to music or, dry needling, things like that.
It occurs to me that all these programs going on, how do people get help? Let's say that I'm a family member or somebody who has a mental health or substance abuse issue. I don't know, I don't know where to start actually to avail myself of all these programs. Do you have advice for somebody who's saying it's time for me to do something? Where should I start?
Who are you asking?
Pretty much anybody.
So the first thing that I would do is
Yeah.
this. I would get an eye patch and a pirate hat, because navigating the mental health
Yeah.
and addiction system is like a treasure map. It is really difficult for a person. They don't know where to start. And just some of the things that you can do is, 988 is a good number. And I'm telling you what, you can't go into a convenience store bathroom without seeing information about 988. It's in churches, it's everywhere, right? But I also think that, just Google can be a good friend. It can be a bad thing, but it can be a good friend in saying mental health and addiction services in whatever county you're in. That's a good one. But I also think, just for me, I just think 988 is the best one. And all of us in this state have mobile crisis now. And actually, if you call 988, you go right to mobile crisis or whatever it is that they feel that you need. That's my take.
Yeah, and I would add the yourlifeiowa.org website.
Yes.
That covers the entire state, and that you can get connected. They'll tell you, you can chat with somebody. They have the information about 988 if you're having an acute crisis. But if you're also not sure that you're not quite at the point where you're ready to call 988, but you just want to find out what's out there, or you're worried about a loved one or a friend or family, someone you work with. If you just want to find out what resources are available, yourlifeiowa.org is a really good resource for all of Iowa. And they have mental health, they have substance use, they have youth, they have gambling, they have a really great broad selection of different resources for people no matter where you are in the state.
Well, those are two good resources, 988 and that website. We could probably talk for another hour. I have several more topics to get to, but we're running out of time. So I want to say very, very much thank you for joining us today and sharing your insights and taking time out of a busy day. So thank you very much. And I especially want to thank our sponsor, ITC Midwest, for presenting Iowa Ideas yet again. And for the people staying with Iowa Ideas for the rest of the afternoon, you're not going to want to miss our closing keynote speaker, Jen Loeb. She is from Marengo, and she is the first Iowa woman to have scaled every highest peak in every continent, and the first Iowa woman to climb Mount Everest. So she has a very interesting story to tell. That's at 1 o'clock. So thank you, everybody, and have a good weekend.
Yeah, thank you.
Thanks.
Bye.